We'll move on now to our second cyanotic heart disease, Tetralogy of Follow. The tetra in Tetralogy of Follow means 4 abnormalities. Let's talk about these 4 abnormalities. The first one is going to be RV hypertrophy, or right ventricular hypertrophy. So why is the right ventricle hypertrophied? Because the pulmonary artery, do you notice how narrow it is over here compared to the wide aorta? We're going to talk about why that happens. But because of the narrow pulmonary artery, the right ventricle has to pump against that stenosis, and because of that it has to hypertrophy to increase the pressure to overcome that stenosis. So we have the pulmonic stenosis that we just talked about, one of the 4 abnormalities, and this causes a harsh systolic crescendo-decrescendo murmur at the left upper sternal border. This is the classic murmur for pulmonic stenosis, and you'll commonly hear this whenever you have Tetralogy of Follow. Another important feature is that you have a single second heart sound. And the reason for that is because the pulmonary blood flow is decreased due to the stenotic pulmonary valve and the stenotic pulmonary artery. So this will cause a soft second heart sound because very little blood is flowing through. But the aorta will have a very loud sound because most of the blood is going through this huge aorta and will have a very loud snapping shut. So it'll be a single A2 component of second heart sound, a single second heart sound. You also have an overriding aorta that covers both the right ventricle and the left ventricle, so both of these ventricles can pump blood into the aorta. And finally, you have a VSD, allowing for mixing of blood between the right and left ventricles. Notice here how unoxygenated blood is entering the systemic circulation. Okay? The reason why this is happening is because the right ventricle is exposed to the aorta, so deoxygenated blood can mix and go into the aorta and into systemic circulation. That's why these patients can get cyanosis. Now let's talk about the reason for Tetralogy of Follow. So this is all due to, just like the last one, transposition of the great arteries, it's due to an improper location and actually deviation of the aorticopulmonary septum. So let's talk about what that means. So say we have the truncus arteriosus over here. We're going to have this line. We're going to call this the normal placement of the aorticopulmonary septum. Alright, this makes an aorta on this side and a pulmonary artery on this side. So the aorticopulmonary septum normally divides the truncus arteriosus into a little bit larger aorta and a large pulmonary artery. But what happens if the aorticopulmonary septum is placed abnormally, such as right here with this red line? Now you have a very tiny pulmonary artery and a huge aorta, and this is what's causing all the problems here with Tetralogy of Follow. Now some signs and symptoms of Tetralogy of Follow. Let's talk about these. Cyanosis we already talked about. Because the right ventricle can pump blood directly into the aorta through the VSD and the overriding aorta, deoxygenated blood or hypooxygenated blood is going to enter systemic circulation, leading to cyanosis. So an important correlation is that how cyanotic the baby becomes depends on how severe the right ventricular outflow tract obstruction is. So the narrower the pulmonary artery, the more likely the severity of the RV outflow tract obstruction and the more cyanosis is present. So a mild obstruction will cause a left to right shunt. There's not much cyanosis at rest because the left ventricle will have more pressure and pump from left to right. But if it's a severe obstruction, the right side will have higher pressure, and as a result, it will go from right to left because you have the pulmonary artery being so stenosed that the right ventricle can't pump into it. So the area of least resistance is the VSD and the aorta, pumping deoxygenated blood or hypooxygenated blood into the aorta and into systemic circulation. We also have these things called hypercyanotic TET spells. So TET spells are classic for Tetralogy of Follow. We're going to talk about what those mean. So these are sudden episodes of cyanosis and rapid deep breathing in children up to 2 years of age with Tetralogy of Follow. So kids that are breathing rapidly and turn blue. And we're going to figure out why this happens. So the 2 reasons why this happens is either decreased systemic resistance or increased venous return. So why would these cause a TET spell? If you decrease systemic resistance, you are now decreasing the amount of resistance in the aorta and the systemic vasculature, so blood is more likely to go into the aorta and systemic vasculature instead of into the pulmonary artery. And since the pulmonary artery is stenosed, any kind of decreased pressure in the systemic circulation will cause a right to left shunt and move blood into the systemic circulation instead of into the pulmonary artery to be oxygenated. Increased venous return also will increase pressure in the right ventricle, but what's the path of least resistance? The VSD and the aorta. So all this increased venous return is going to go directly into the right ventricle, and instead of into the lung, it's going to go into the aorta or into the left ventricle. So examples of this are hypotension, feeding, defecation, and crying. Hypotension, you have decreased resistance because you lose volume. feeding, defecation, crying will all increase venous return, and these will all cause the TET spells that we see. We have increased right to left shunting of blood across the VSD, which we just mentioned, because of these two causes. And we have decreased oxygen saturation of the systemic blood. So you have decreased PO2, increased PCO2, and decreased pH due to hypoxemia in the arterial blood. And that's going to cause hypoxic vasoconstriction in the lungs, which causes increased pulmonary vascular resistance. Remember, if you have decreased oxygen in the lungs, you have increased pulmonary vascular resistance to shunt blood to other areas that have more oxygen exposure. And you have stimulation of central and peripheral chemoreceptors, which cause tachypnea and deep breathing. And what is this going to do? It's going to increase negative intrathoracic pressure, and now you get even more venous return to the right heart. And remember, what was the problem in the first place? Too much right to left shunting, too much venous return. You increase the venous return more, and you cause even more problems. So you have a cycle that forms due to more blood on the right side. So this is why having this tetralogy of Follow, all these signs and symptoms, and having all these 4 defects can lead to major problems, because this is not a normal way the heart's supposed to look, and the cycle that the body uses to protect itself actually harms the body by increasing the right to left shunting in the end. We've always heard that squatting is important for Tetralogy of Follow TET spells. Putting them in a knee to chest or squatting position can help with the TET spell. How is that the case? So the reason why this happens is that when you squat, you compress your vessels and increase the systemic vascular resistance, so you have more of a resistance to the left ventricular outflow and aortic outflow. So because of that, more blood can go into the pulmonary artery. And by more blood going to the pulmonary artery, you get more oxygenation. And as a result of more oxygenation, you lose the hypoxemia that's causing all these problems. So now let's talk about dyspnea with feeding. So you get dyspnea with feeding with Tetralogy of Follow because you get more right to left shunting. Whenever you're feeding, you're going to have a decreased intrathoracic pressure and more venous return with more blood coming into the right heart, and you get right to left shunting. So this is why you get dyspnea with feeding. The body can't meet the heart can't meet the metabolic demands of the body. You also get a lot of heart murmurs with Tetralogy of Follow, and these are associated with its 4 causes and 4 signs that are associated with it that we talked about in the previous slide. You get a right ventricular outflow tract obstruction, pulmonic stenosis. We talked about the murmur there, the systolic crescendo decrescendo murmur. We also have a VSD murmur, and the smaller it is, the louder it is, and the larger it is, the softer it is. And the reason why is because of pressure gradients. If you have a small VSD and you have more pressure on one side than the other, you're going to have a loud sound that's equalizing the pressures. But if you have a large VSD, you're not going to have much of a sound because there's not much resistance, there's not much of a valve, so blood can easily mix back and forth between the left and right ventricles without making a loud sound. You have a harsh pansystolic, holosystolic murmur at the left lower sternal border. That's classic for VSD. So remember, a large VSD, there's not a major resistance between the two sides, left and right ventricle. You won't have a loud murmur. But if you have a very small hole or small VSD, you've got a resistance, that valve itself or that hole itself, and you get a louder murmur as a result. You also get a parasternal heave, because remember, right ventricular hypertrophy is a major issue with Tetralogy of Follow, so that'll cause the sternum to heave or push forward intermittently during the right ventricular contraction. Now let's talk about the diagnosis of Tetralogy of Follow. So we have a couple ways we can diagnose. Remember, first is stabilization, then it's chest x-ray EKG, and then it's echocardiogram, and then you treat it with whatever the treatment is, which we'll talk about. So on the chest x-ray, this is called a boot-shaped heart. So boot-shaped heart is what you want to look for on a chest x-ray, and the reason why is the right ventricle is so large it pushes the left ventricle outward, and what you see over here is the overriding aorta. All right, it almost looks like it's part of the heart, but this is an overriding aorta that's associated with the 4 symptoms of Tetralogy of Follow. So you have prominent right ventricle and decreased pulmonary vascularity. Why do you get decreased pulmonary vascularity? Because you have the pulmonary artery stenosis and you cannot get as much blood going into the lungs. EKG shows RV hypertrophy and right axis deviation. Right axis deviation because the right ventricle is larger than the left, so the leads will have more electricity going towards the right side. So you get a right axis deviation. When the right side is larger, the EKG leads shift to the right, causing a right axis deviation. Echocardiography, as always, is the best way to diagnose these conditions. Now let's talk about management and treatment. So if you have a severe right ventricular outflow tract obstruction at birth, you need to give a PGE1 agonist to maintain the PDA. All right, so if you have a patent ductus arteriosus, that'll be very helpful because that can allow blood from the aorta to mix with the blood in the pulmonary artery and get more blood oxygenated. So that's very important. It allows for a left to right shunt from the aorta to the pulmonary artery to allow for blood oxygenation in the lung and more oxygen for the body to handle. Now for the TET spells we just talked about in the last slide. How do you treat these? So there are multiple ways to treat them, and we'll talk about each of these. You need to first give high flow oxygen via face mask. Remember, we talked about the hypoxemia and low oxygen in the blood causing a increased pulmonary vascular resistance. But if you give oxygen, you'll decrease the pulmonary vascular resistance, and that'll help the patient completely by causing there to be less resistance to right ventricular outflow through the pulmonary artery. Also, crying, as we noticed, worsens the TET spell and cyanosis by increasing venous return, so you want to calm the baby down as much as possible. Also, knee-chest position and squatting, we talked about that, increasing systemic vascular resistance. And if these don't resolve the TET spell, you need to do something to non-organically increase systemic vascular resistance. You'll give a drug. An alpha-1 agonist will increase systemic vascular resistance by causing vasoconstriction. That'll cause more of a left or right shunt. And a beta block will also decrease cardiac output by decreasing contractility, mainly the left ventricle, and it will cause more preload and cause more blood to go left to right as well. So these are the last line treatments. And surgery, as always, is a definitive treatment. So if a patient has one severe TET spell, they need to have surgery to fix this because a TET spell can be lethal.